This is a patient where there was a chronic inflammation post-operatively due to TASS being created by a hydrophilic multifocal IOL. We waited for the patient to settle down for nearly 2 months, and every time we stopped the steroid, the TASS and the anterior chamber reaction would come out again. So we decided to go ahead and explant the lens and implant a secondary IOL, probably at a later stage. Due to chronic inflammation, we can notice that the pupil has become small, fixed, non-dilating, and also there is intense fibrosis of the capsular bag. Now this poses a tricky situation for removal of a plate haptic IOL through a small non-dilating pupil with a fibrotic adherent capsular bag to the lens. So we go inside to inspect all sides, and we, as expected, are seeing dense fibrosis and adhesions of the anterior capsule to the anterior surface of the IOL and a possible adhesion of the posterior surface of the capsule to the IOL. We try and rock the IOL to see whether does the lens move freely within the capsular bag, but we are disappointed. The adhesions seem to be firm. So we now decide that due to a small pupil size, we will have to instill iris hooks at strategic positions where they would help us to enlarge the pupil, but at the same time also give us a good decent view of the capsular bag and the fibrosis and warn us if the capsular bag is being torn while removal of the lens or the capsular bag is being removed during removal of the lens. The trick of putting these iris hooks is that never stretch one iris hook completely at its position. The best method is to titrate the tightness of the lock of iris hook one at a time and till we reach an adequate dilatation. And especially in an inflamed iris, it's not a good idea to stretch the iris too much, as the iris hook may cut through or cheese wire through the iris. Now we can see that we have a complete view of the iris and the capsular bag with fibrosis. Now we try and rock the IOL again, and now to our surprise, there is some movement which is happening in this area. So now we dislodge the anterior capsule and separate the anterior capsule from the anterior surface of the IOL. Once that is done so, we want to deliver this particular part of the IOL which has been separated from the anterior capsular axis by going underneath the IOL and scooping it out of the capsular bag. This movement has to be gentle and not jerky, because this inflamed capsular fibrosed bag can tear or can subluxate along with the IOL completely into the anterior chamber. Now since we have delivered the loose part of the IOL, one end of the IOL has been brought into the iris plane, we proceed to put viscoelastic to protect the endothelium. Now it is time to remove one of the iris hooks, because this iris hook will be a hindrance to the rotation of the IOL and removal of the IOL and may cause an iris tear. Once this iris hook has been removed, we very gently rotate this plate haptic IOL in a coupling manner, which means we do a bidirectional rotation of rotating one end at a time, so that all the forces of rotation are not being concentrated at one end, because this may cause a dislodge or breakage of the fibrosed capsular bag. So you will notice we rotate one end and then we use rotational force on the other end, and then back and forth till we have rotated the IOL into the plane of the wound. Now you will notice that retained iris hook is giving us a good view of the capsular bag and telling us that the bag is not rotating along with the IOL rotation, which is a good sign. So this retained iris hook was kept there with this particular purpose, to give us a good visualization of the way things are going. Now we enlarge our initial 2.8 mm incision with using a 5.25 mm keratome and create an incision of approximately 4 to 4.25 mm. We again instill viscoelastic to protect the endothelium. Remember, installation of viscoelastic is very important to stabilize the bag and also protect the endothelium. Using a blunt instrument, we rotate the loose end or the deliver edge of the IOL into the anterior chamber. Go and hold it with a forceps and gradually, slowly remove the lens while keeping an eye on the capsular bag and the fibrotic area. The lens has come out beautifully. There has been no breakage or damage to the bag or the zonules. We proceed to remove the iris hook. We sutured this wound now because we need to remove the viscoelastic and wash the anterior chamber very properly, so that we don't want to leave any inflammatory tissue or inflammatory cells within the anterior chamber, because the suture would prevent iris prolapse. Now once this is done, we close the case because we are planning to put a secondary IOL in this particular patient, which was done after 2 weeks of waiting, once the eye was quiet and non-inflamed and everything went according to the plan. Thank you.